We're really excited to have you join us today to discuss innovations in cancer nutrition across the ages. So here's our plan for the next hour or so. We're hoping to unpack how nutrition needs and what challenges are faced across the lifespan. And of course, we'll weave in a number of practical, evidence-based tips and resources to help you beyond this webinar. A cancer diagnosis can be confronting and overwhelming for everyone or anyone at any age. It's estimated that 2 in 5 Australians will be diagnosed with cancer by age 85. So today we're diving into the fascinating intersection of cancer and nutrition across different life stages. As we know, cancer care has rapidly evolved. Groundbreaking diagnostic tests and procedures, new treatments, and cure rates never seen before. And this is changing how we approach optimal nutrition at various ages. So broadly speaking, working as dietitians and providing nutrition care in Australia for people with cancer, we typically observe only a small proportion of our work in the inpatient setting, the majority in an outpatient or clinic-based setting. We're commonly focused on managing nutrition impact symptoms, preventing and treating malnutrition, sarcopenia, and other nutrition disorders. We utilise oral, enteral, and parenteral nutrition support, and we are constantly leaning into our skills in behaviour change. But today, we're going to change tact a little bit. We're not going to cover the bread and butter of cancer nutrition care. We're going to focus on 3 key life stages, so adolescents and young adults, middle-aged and older adults. We hope to highlight these stages through case studies, so helping you to critically consider why nutrition is vital, how this fits into the broader context of someone's life, and how you can make a difference. So by understanding the nuances across these life stages, we're hoping that you'll be able to better apply nutrition information in practical ways to improve care outcomes. So here are today's learning objectives. So firstly, we're going to look at and get you to hopefully understand why nutrition is not a supplementary aspect of care, but a vital component of cancer care that varies across different life stages. Secondly, we'll explore the various patterns, issues, and innovative approaches in cancer nutrition care that emerge at each of these key stages of life. And finally, we wish to improve our practical application of this knowledge, so transforming insights and actionable steps that can enhance the well-being of our patients. So the first life stage we'll cover is adolescents and young adults, or AYAs, with cancer. They're typically defined as being 15 to 25-year-olds. So AYAs have distinct healthcare requirements when compared with children and also compared to older adults. And unfortunately, they often fall between the cracks in care. So the AYA years mark a time of crucial development of social roles, of health behaviours and attitudes. And at this age, cancer, unfortunately, is a major contributor to both disease burden and death in Australia. So cancers in AYAs are in fact quite rare, but they have an enormous impact. The most common cancer types we see in AYAs are hematological cancers, melanomas of the skin, and testicular germ cell cancers. So in line with these common diagnoses, we see treatments span all modalities, but frequently we see chemotherapy used as a primary treatment. So the key considerations we want you to highlight to you today are that the AYA years are a time of significant developmental transition. So these impacts stretch across biological, physiological, social, and mental health domains. This time of the AYA years is super critical to growth and development, to education and vocation attainment, to peer and family relationships, the establishment of social roles, and gaining independence. So in addition, we see AYAs are going through things like moving out of home, they're cooking for themselves for the first time, they're navigating alcohol and drug use, they're living via social media, they're exposed to peer pressure, struggling with body image concerns, working out their sexual identity, and more. The AYA nutrition pathways of care are, unfortunately, largely underdeveloped. So nutrition care for paediatric groups is typically very proactive. And likewise, we're starting to see this more so in high nutrition risk adult groups. So for example, in head and neck cancer. But for AYAs, there's definitely more work to do. So as mentioned in Nina's bio, there's a nutrition study that's being led by Peter Mac and the statewide AYA service in Victoria that's recently finished, and findings will be available soon that will help us to quantify the extent of the nutrition issues and help define a way forward in nutrition care for AYAs. Age-appropriate communication is a critical aspect of working with this group and also a primary indicator of quality AYA healthcare. So this is something that we'd encourage clinicians to upskill in. For dietitians, this also highlights the importance of discussing things like credible sources of nutrition information. So how to make use of AI and social media, and gently combating misinformation in a world of increasing online nutrition myths. So what's critical and unique to this life stage? Well, AYA cancer care is done differently. So ideally, AYAs are treated in a specialty centre whereby the environment provides the patient with a sense of control, offers access to positive distractions, and also social supports. The photo here shows our youth centre at Peter Mac, a comfortable space that's got a fully equipped kitchen, snacks available, a lounge and TV space, quiet spaces for rest, study or work, and also the opportunity for patients to connect with other AYAs. So we see AYA often having to straddle the difficult transition between paediatric and adult hospitals, and certainly having a specialised space can help support a sense of normality for them. So care to this group must be age appropriate. So ideally it follows a hybrid patient-centred model of care. So what I mean by that is it's family inclusive. So whereby the AYA is supported whilst their autonomy is emerging, but also being adaptive in involving parents and carers. So I'll point you to the Cancer Council's Optimal Care Pathway for AYAs, which provides a fantastic framework for cancer care in this group. AYAs, unfortunately, also have a lifetime of worry. So if they're cured from their primary cancer, they're at an increased risk of developing a second cancer, increased risk of other health conditions such as obesity, cardiovascular disease, fatigue, and other issues like insomnia. And from a psychosocial perspective, we see up to a third of all AYAs with cancer and their parents in Australia experience moderate to severe anxiety and depression. So on top of a heightened fear of cancer recurrence, you can see why AYAs face a really unique set of challenges resuming healthy lives after cancer. So now Nina's going to introduce our first case study.
Thanks, Jenelle. So let's call her Emily. So Emily is a 19-year-old woman who's recently moved to Melbourne from rural Victoria to study communications at uni. She's living out of home for the first time in a share house, while her family are over 3 hours away, back on the farm. She's juggling uni with part-time work in hospo and occasional tutoring. And she was excited to move to the city. She was looking forward to meeting new people, uni parties, joining a local hockey team, landing an internship at her dream employer, maybe saving for her first overseas trip, and potentially even going on a first date or two. But all of this was turned on its head when Emily was given a diagnosis of Hodgkin's lymphoma and the fear and uncertainty that comes with a cancer diagnosis. Suddenly, she finds herself with an endless list of appointments and waiting around in hospital waiting rooms for what feels like an eternity, and missing the support of her family and Spud the dog. So Emily's planned for curative intent chemotherapy. So let's hear from her medical oncologist now to learn more about her situation.
Emily has been diagnosed with Hodgkin lymphoma, which is the most common cancer seen in young people aged between 15 to 25 and accounts for approximately 15% of all cancers diagnosed in young people. Hodgkin's lymphoma is a cancer that is associated with a very high chance of cure, now approximating over 95 to 98% chance of success. But in order to achieve that, young people need to undergo fairly aggressive style treatment For Emily, this looks like receiving a fairly aggressive style of approach, given that she has presented with fairly extensive disease and will receive 7 drugs of chemotherapy given both intravenously and by tablet. The chemotherapy often occurs at a 3-weekly cycle, including 14 days worth of high-dose prednisolone, or otherwise called steroids. Depending on how she responds to her treatment, and normally we conduct imaging after a few cycles, she will require approximately 4 to 6 cycles in total, which would last 18 weeks worth of duration. Chemotherapy can come with a range of both acute, medium, and long-term side effects. In the acute setting, Emily may notice fairly significant nausea and vomiting and sometimes flu-like symptoms, as the chemotherapies can affect her stomach lining. Within the first 2 weeks, chemotherapy can impair her immune system, cause some damage within her mouth, causing mucositis, cause some non-specific gastrointestinal side effects such as constipation, and also can cause issues with rashes and damage to her nerves. One of the significant concerns of these types of regimens is that these chemotherapies can cause some long-term damage, and given the high chance of cure, the long-term effects of these chemotherapies are a significant concern for a young population. And particularly with Emily, she is at risk of having an impact on her fertility status and with her cardiac health or heart health. With regards to her fertility, all young patients are offered fertility preservation strategies in the chance that her fertility is impacted by her chemotherapy. Particular to this type of chemotherapy, the cumulative amount of steroids that gets used can lead to a range of very significant steroid-related side effects, such as insomnia, fluid retention, mood changes, increasing appetite, and potentially weight gain. Most importantly, we understand that although we can achieve high success rates, we are trying to minimize the long-term morbidity of these chemotherapy treatments. So that highlights the importance of working together both within pediatric and adult approaches to care to improve overall outcomes at the same time as minimizing the long-term effects of her treatment.
And now we'll hear from our AYA Program Director.
So in considering Emily's case, we might consider who might we refer her to within the multidisciplinary team. We might consider a nurse for some additional specialised targeted education and support. We might consider a social worker to help support her with her adjustment to her diagnosis, but also to deal with some of the practical issues that might arise regarding employment, finances and accommodation. We'd also be thinking about Emily's overall mental health, with a low threshold in consideration to referral for psychological support to assist her in navigating the complexities not only of her diagnosis now, but the impact on her life, both as an individual, but also within the context of her life and her community.
Because of the known side effects of her treatment, Emily was referred to nutrition early on. So we completed a comprehensive nutrition assessment with Emily that included anthropometry plus a PGSGA, which is a malnutrition assessment tool validated for use in oncology. We also looked at biochem, clinical symptoms, and a diet history too. From our social history, we know Emily has concerns around budgeting for meals and fatigue impacting on her ability to cook and shop, particularly for the first few days after each cycle when the steroids wear off. So, how can we support her? Our goal was to provide Emily with the skills to plan, buy, and cook in bulk a range of cost-effective, nutritious meals that she enjoys. This meant that when the fatigue kicked in, she had nutritious meals ready to go in the freezer, and meant she was no longer blowing her budget on Uber Eats. We also looked at boosting the nutritional density of quick, easy meals she was already making. So Emily's go-to, like many other uni students out there, of instant noodles became a high-protein meal with the addition of tinned fish, an egg, and some frozen veg. We also talked about accepting help and thinking about what practical supports would be most helpful for her as friends and family continued to offer their support. As a result, Emily received home-cooked meals, help with meal preparation, grocery vouchers, recipe boxes, and even vouchers for her favourite takeaway spots. Engaging roommates in communal meals some days also helped to share the load and prompt Emily to eat on those exhausting days after each cycle. It also brought back some of the social and enjoyable element of meals that Emily had been missing since she moved out of home. And this is a trick I picked up from Emily. She used something called habit stacking to her advantage during treatment. So habit stacking is a technique where used to form a new habit by attaching them to existing ones. So I bet you all brush your teeth morning and night without even having to think about it. So Emily started drinking a glass of water every time she brushed her teeth to help meet her hydration goals, sorry. She also grabbed a protein-rich snack, usually a yogurt or some cheese and bickies, anytime she sat down to watch an episode on Netflix. She also used AI into her advantage during her treatment, using it to generate high-protein recipe ideas using ingredients she already had on hand, and creating budget-friendly meal plans with a shopping list to help manage her grocery budget. So discussion around AI and its uses started a broader conversation with Emily about where else she was sourcing information. So as dietitians, we know there's a lot of misinformation out there. Low sugar, no sugar, juice cleansers, coffee enemas. These are just some of the things your patients may be coming across online. And you can see I had a little bit too much fun with the AI image generator, especially for the carnivore diet there. But in all seriousness, our AYA patients live in a digital world, so it's important to explore where they're getting their information and normalize conversations about what they've seen online. Many turn to the internet to find food and nutrition guidance as a way to regain a sense of control during a difficult and uncertain time. And so as dietitians, we need to approach these discussions with curiosity, empathy, understanding, and be ready to gently address misinformation while validating their needs to feel empowered. So I just wanted to share a couple of the resources we often use in practice. So this is a great one from the VCMC. It's a myth-busting resource. It's practical, evidence-based, and it's designed to help patients navigate some of the common nutrition myths in cancer care. It's a great tool for starting conversations, addressing that misinformation, and in supporting informed dietary choices in your patients. And it's great, you can email it to them or share the QR code, and young patients in particular can just bring it up on their phone rather than being handed a pile of clunky resources they might not use. The other one we use quite frequently is the Cancer Council's I Heard website. So this website tackles cancer-related myths and misinformation circulating online. And it's a useful resource for patients and also clinicians for that matter to fact check claims and get clear evidence-based answers. And you can even submit questions about things that you're not sure about. I wanted to share a quote from an AYA patient who said, "I actually found food was a huge relief, the only thing that made me feel normal." To highlight that nutrition is not only crucial to physical well-being during cancer treatment, but they can also provide comfort and a sense of normality when so much else feels uncertain or difficult. As we've learned from Emily, and for any AYA patients you may be supporting, there are a few key things that are critical to remember. Don't be afraid to be guided by your patients. Ask questions, be open-minded, and give them choice. They may just teach you a thing or two.
The second life stage we'll cover today is middle-aged adults with cancer. So this is a less well-defined age bracket, but for the purposes of today, we'll describe this as being between 40 and 55 years of age. So cancers in middle-aged adults are relatively common. And in fact, we're seeing an increase in cancer incidence rates for middle-aged people, noting most cancer cases in those under 50 years old are people in their 30s and 40s. The most common cancer types we see in this age group are breast, melanoma of the skin, colorectal, and thyroid cancers. And in line with this, again, we see the full breadth of treatment modalities offered. Quite likely it's a combination of treatment modalities in this age group, but we do tend to see surgery as a really common first-line treatment at this age. So some of the key considerations for middle-aged adults with cancer include, in particular for people in their 40s and 50s, this is typically their career prime. They might hold positions of responsibility, potentially they're more financially secure than ever before, although this is not always the case, especially within the current climate of the current cost of living. This age is more commonly also referred to as the sandwich generation. So dually caring for young dependent children and at the same time, aging parents. So this squeeze, so we're combining caring responsibilities, a busy professional career and time pressures in day-to-day life is really brutal. So then imagine a cancer diagnosis on top of this, and obviously this can be hugely impactful. So the vast range of issues that a middle-aged person with cancer will experience are largely dependent on what diagnosis they have and what treatment they undergo. However, at this age, other physical and psychological changes are really critical to consider. So this age group, I guess on the whole, is relatively well and healthy, but it's important to mark that this is also a time of age-related physical decline, and for women, perimenopause, so where additional physical and psychological challenges occur. So what's critical and unique to this life stage? Well, we're seeing increasing cancer diagnosis rates for people in their 40s, so for thyroid, breast, prostate, colorectal and kidney cancers. And what's driving these rates is multifactorial. So one key factor are the increasing rates of obesity and poor lifestyle. And another key factor is the rising number of early onset bowel cancer cases. So for this, traditionally, bowel cancer has been considered an older person's disease. And so commonly middle-aged adults with presenting symptoms have reported facing age bias. This is slowly changing as awareness of the commonly presented symptoms of bowel cancer are growing, and also as the stigma surrounding this is reducing. Precision oncology is something to get excited about. So described simply, it's to deliver the right cancer treatment to the right person at the right dose at the right time. So it uses an individual's genetic and molecular information to tailor therapy, but it also spans individualizing therapy based on a person's nutritional and health status, perhaps their microbiome, and using advanced methods of assessment to achieve therapeutics beyond what we're using now and as dietitians do today. Another critical component of this age group is the importance of survivorship. So addressing the survivorship needs for this group is really important, as we're seeing cancer cure rates improving. But in particular for middle-aged adults diagnosed with cancer, it's important to understand that they probably have another 40 or more years of life ahead of them. So the vast range of long-term physical and psychological effects of treatment, or perhaps it might be living with an incurable cancer, are really critical to understand. So for people after cancer treatment, it would be really rare to have no residual symptoms or mental health concerns for the years following cancer treatment.
So let's move on to our next case. So Kylie was diagnosed with rectal cancer in her early 40s. As a busy working mum with no family history of malignancy, it came as a shock. Kylie lives at home with her partner, 3 young children, and Ducky the rescue cat, and juggles this with her full-time role in management. I really wanted to highlight Kylie's experience today because, as Jenelle mentioned, colorectal cancer incidence is increasing among younger Australians aged less than 50 years, and as such, we're seeing a lot more people in Kylie's situation coming through our clinics. So as far as treatment goes, Kylie seemed relatively straightforward. A date for surgery was set, and she was pleased that she didn't require any neoadjuvant chemotherapy or radiotherapy. Kylie underwent an ultra-low anterior resection to remove the tumour, where the lower left part of the colon and all of the rectum are removed. It's a really specialised procedure aimed at preserving the anal sphincter. Kylie had a temporary diverting ileostomy formed. So this was to divert faeces away from the anastomosis, which is where the 2 bits of the bowel were joined after the tumour was removed, and in doing so, to reduce the chance of an anastomotic leak. Kylie had a smooth post-operative course and was discharged home to her family. When we followed her up in outpatient clinic a couple of weeks post-op, she was doing well from a nutrition perspective. She coped well with her stoma with the support of the stomal therapy team, but looked forward to having it reversed in a few months and getting back to normal, as she put it. So finishing cancer treatment is often marked by ringing the bell, a moment of celebration, but also of relief. But what actually happens on the other side of cancer treatment? 3 months after Kylie's initial surgery, she had her ileostomy reversed. So this involved going back in for another operation to reconnect her bowel and close her stoma. As she was discharged home from the ward, Kylie rang the bell, marking the end of this chapter. But it's right about here that Kylie's story takes another turn. So BC, or before cancer, Kylie had enjoyed coffee and pastries, park run and bike rides, cooking for friends and family, preferably with a glass of wine in hand. But things had been a little different since she had her stoma reversed. When Kylie left the hospital, she was told her bowels would settle in time. But a few months on, she's finding she still gets caught out. She has fecal urgency, frequent bowel motions, often going up to 15 times a day. She's incontinence of wind and sometimes of stool too. She has clustering, where she has to open her bowels multiple times in a short time, and a feeling of incomplete emptying, even when she's gone over 15 times. Now she finds herself dreading social events, constantly mapping out the nearest public toilet, eating a bland diet, or even skipping meals altogether. She carries an emergency bag everywhere she goes, and has even found herself missing her stoma, something she'd never thought she'd feel. So Kylie returns to her surgeon and her care team and to find out what's going on, and is diagnosed with a syndrome called low anterior resection syndrome, or LARS for short. So to understand what LARS is and how that's impacting Kylie, let's take a quick anatomy refresher. So the rectum's main job is to store stool until it's a convenient time to go to the bathroom. And the rectum senses when it's full and signals the brain to trigger the urge to defecate. Along with the anal sphincter and the pelvic floor muscles, the rectum is vital in maintaining fecal continence. Think of it a bit like a storage tank and also communication centre for bowel movements. But after Kylie's initial surgery, her storage space is much smaller or gone altogether, and the nerves and the muscles controlling her bowel have likely also been affected. So no wonder she's having so much trouble. After Kylie was diagnosed with low anterior resection syndrome, or LARS, she was referred to a specialist pelvic floor physiotherapist, a nurse consultant, a psychologist, and a dietitian. And the goals of her care here were to support bowel regularity, reduce urgency and frequency, but most importantly, to get Kylie back to the things she enjoys most. It was so important not to be housebound for Kylie, as work's a huge part of her identity, but also she was finding it difficult not to be able to leave the house as much to watch her kids' sport games and support her elderly parents. So multidisciplinary team management here included the use of antidiarrheal medications such as loperamide, transanal irrigation, and also psychology support for coping with the psychological impact of LARS. But today we'll focus more on the nutritional management. So nutrition advice focused on identifying trigger foods, improving stool consistency, and nutritional adequacy. Kylie found keeping a food and symptom diary helpful for identifying trigger foods. And unfortunately, she found her caffeinated fluids, particularly her beloved lattes, spicy foods, high-fat foods, alcohol, and foods high in insoluble fibre were particularly problematic. To improve her stool consistency, we discussed reducing trigger foods and including some starchy foods and soluble fibre supplements to thicken her stools and give her greater control. And I wanted to play a short clip here from one of our incredible pelvic floor physiotherapists who work closely with patients like Kylie in managing LARS.
Pelvic floor physio usually involves a thorough assessment of patients' symptoms and goals. Treatment usually involves an individualised pelvic floor exercise program, education and advice about defecation dynamics such as toilet positioning, wiping techniques, other toileting advice. We also address any other pelvic floor dysfunction issues such as bladder issues, sexual function. We rely heavily on our dietitian friends to help us manage and manipulate the stool consistency to help with continence.
So with support from the team, Kylie was able to return to the office utilising strategies to manage high-stakes situations like using transanal irrigation, gastrostop, and avoiding trigger foods before important board meetings or kids' birthday parties at the park. As Kylie's symptoms continue to improve, we'll focus more on general healthy eating principles for long-term health, but also for survivorship.
And the third and final stage we'd like to cover today is older adults with cancer, so defined as 65 years and older. So this group possibly makes up the majority of the cancer patients that you may see in your practice, as the median age of a cancer diagnosis in Australia is around 69 years. So this group is also an area of priority as noted within the Australian Cancer Plan. So the profile of a typical cancer patient is in fact an older person with cancer. So an estimated 88% of those diagnosed with cancer will occur in people aged 50 and over. So furthermore, we're seeing a rise in the number of cancer diagnoses overall in Australia, with the same patterns seen globally. And this is exacerbated by an increasing population size, people are living longer, and improving cancer survival rates. So the most common cancer types we see in older adults are very closely aligned to the most common cancers we see in Australia: prostate, breast, colorectal, lung, skin cancers, and melanoma. Again, for this life stage, we'll see the full breadth of treatment modalities and combinations of these offered to this age group. And it's really important to note that the selection of treatment modalities is somewhat more complicated in this age group, as so many different factors need to be considered. So some of the key considerations for older adults would like you to keep in mind. As noted, the number of people with cancer in this age group is increasing and will continue to do so. So if you're working in oncology, it's really important to know what the best practice approaches are and how to manage these older adults in your practice. For most older people, a cancer diagnosis will commonly occur alongside another chronic disease. So this adds a layer of complexity to nutrition care. And treating people as individuals and care being designed around what matters most to older people is really critical. It's also important not to judge a book by its cover or age. So I'm sure we've all seen an 80-year-old that is frail and needs lots of support, but equally, we've probably all seen an 80-year-old that's incredibly robust, still playing golf twice a week and living independently without any issues. So what's critical and unique to older people with cancer? Well, multidisciplinary care, as we know, is required for all patients with cancer, but absolutely critical for the effective management of an older person. So this means taking into account an array of factors, such as managing other conditions or multimorbidity, polypharmacy, perhaps a complex or an isolated social situation, or it might be simply considering the decline in physical and mental capacity that happens at this age. Geriatric oncology is now recognised as a specialty in itself, so emphasising the complex intersection of these two areas. So this area of medicine will play an increasingly valuable role as the number of cancer patients in our community grows, and will help tackle issues such as ageism. An optimal care pathway for older people is currently under development in Australia by a multidisciplinary team of experts spanning both oncology and geriatrics. So please look out for this important guidance document, which I'm sure is coming soon. And lastly, I wanted to point out both age-related and cancer-related sarcopenia are prevalent conditions alone, but in combination really do create a perfect storm of nutrition risk, a decline in muscle health, and negative consequences for older people with cancer.
Thanks, Jenelle. So let's meet Les. Les is a 78-year-old retired gentleman who's been diagnosed with non-small cell lung cancer. He lives independently at home following the loss of his wife 2 years ago, with both of his adult children living interstate and limited family support nearby. Les manages on his own. He's planned for 6 weeks of concurrent chemoradiation with curative intent. And while combining chemotherapy with radiation enhances the effectiveness of treatment, it also increases the risk and severity of side effects. Les already has several existing health conditions and is feeling overwhelmed about managing his usual medications alongside the new ones prescribed for his cancer treatment. To make matters worse, his beloved canine companion dies in his first week of treatment. So Les is automatically referred to the dietitian for high nutritional risk treatment, particularly as part of his esophagus is in the radiation treatment field. And we know common side effects from Les's prescribed treatment include poor appetite, nausea, vomiting, reflux, fatigue, mucositis, pain on swallowing, and esophagitis, among other things. And a key goal of nutrition during chemoradiation for lung cancer patients like Les is to prevent weight loss and preserve muscle mass. So the research shows that patients who lose more than 5% of their body weight during treatment are at higher risk of developing radiation-induced esophagitis and tend to have earlier onset of symptoms compared to weight-stable patients. Les was reviewed fortnightly by the dietitian during the initial phase of his radiotherapy, but we bumped this up to weekly sessions as his symptoms worsened. And you can see this graph here illustrates the severity of side effects as treatment progresses. And it's important to note that symptoms typically peak in the final week of radiation and may persist for several weeks after treatment ends. So you can see Les is not out of the woods just yet. But let's fast forward and focus on Les's final week of treatment, week 6. So it's here that he's admitted to the ward for pain management due to pain on swallowing and esophagitis. And Les mentions he's been struggling to remember when and how to take his pain medications at home. His wife used to take care of all that. And this is made even harder by the chemo-related brain fog. He's also been finding it difficult to prepare meals for himself, with fatigue and other treatment side effects taking this a toll. And he doesn't want to bother his mates for help. So first we'll look at what we're doing from a nutrition perspective. So Les is managing on a soft, high-energy, high-protein diet, and we plan to increase his 2 cal subs to 2 to 3 a day if he's maintaining his current oral intake. We also broach the idea of enteral feeds, discussing that a nasogastric tube may be necessary if he's unable to maintain adequate nutrition orally, but Les is pretty keen to avoid this for now. We also discussed timing of analgesia around his meals, and as such, the home team swapped his soluble paracetamol to 20 minutes prior to main meals and lignocaine 5 to 10 minutes prior to meals. So by better managing Les's pain, we're able to help him manage more oral intake too and manage his primary concern. We also reiterated the importance of high-energy, high-protein diet in final weeks of treatment, but also in the acute recovery phase post. We encouraged him to continue texture modification as required and food fortification again when he's back at home, but also discuss the typical post-radiation trajectory and realistic recovery for timeframes too. And we had a little help from Rocky, one of the beautiful therapy dogs here at Peter Mac, to help boost Les's mood too. So pleasingly, Les's oral intake improves with adequate analgesia, and with his pain better controlled, he's able to tolerate more oral intake in his supplements and narrowly avoids a nasogastric tube. We also referred Les to social work to help set him up with Meals on Wheels before he goes home and other supports back in the community. So let's hear from Les's multidisciplinary team. But first, I want to point out that Les's main goal at this point was to return home and live independently as he had been prior to his admission, but also to get back to enjoying meals at the local RSL with his mates like he used to. So this is front and centre when we're considering his discharge planning. But first, let's hear from Les's pharmacist.
For discharge, we probably need to consider making sure we're educating Les a bit better, giving him a few sessions where we talk about medications rather than just overloading him with information on discharge. We'll also make sure that we give him a medication list and go through that in depth with him, but he will need to have follow-up with, we do have pharmacists in clinic, in the radiotherapy clinic sometimes. We can actually get access to a pharmacist there who can actually help him with his medications as well.
Now, social work have already placed a referral for My Age Care for community supports for Les when he returns home, and also for a soft Meals on Wheels diet to start when he's discharged. But let's hear how else they're supporting Les.
When considering other needs for Les, it's important to note that he has some recent loss with his wife 2 years ago and his pet dog at the beginning of treatment. So it would be important to conduct an assessment of any emotional support required for Les, and something we could think about to address this during his inpatient stay is a potential referral to music therapy and looking at any links to community-based emotional support.
Next, we'll hear from Les's physiotherapist.
Okay, so we've ascertained that he is safe on the wards. He's probably going to be safe to go home, but we could certainly get other allied health disciplines involved as an inpatient to better support him, particularly social work and occupational therapy is what I'm thinking, as well as obviously nutrition. So what do we want to do to optimise him at home? We need to think that he is struggling with esophagitis, so he's probably got loss of weight, he's probably got loss of muscle mass and sarcopenia. So we would want to work with either the physio team or our exercise physiology team here to to develop a home exercise program for him, or pending location coming into our service here, to be really looking at some resistance-based exercises to start to improve his muscle mass and keep him as functional as possible at this time.
So, great news, Les is discharged home. So on discharge, he's pretty happy to have a follow-up appointment with nutrition in a couple of weeks. And over the following weeks, we continue to look at strategies to support his nutrition and overall goals. And although his goal of enjoying a T-bone steak and chips at the RSL is still a little way off, he's open to considering softer options, maybe the lasagna, to get him back to enjoying social meals with his mates. Les is aware of the importance of a high-energy, high-protein diet to prevent treatment-induced muscle wasting. But now we focus more on continuing this in the longer term to prevent age-related muscle decline. Now, Les's story is just one example of how vital the multidisciplinary team are in supporting and optimising our nutrition care, especially when patients face complex social challenges such as living alone, social isolation, and limited support networks. Back to you, Jenelle.
Thanks. So now we've walked you through the lives of Emily, Kylie, and Les. And we wanted to just share some of the resources that we certainly find helpful and that you may or may not know about. So the ones listed here are helpful for clinicians working across any age group. And just noting, this list covers some relevant cancer and nutrition, evidence-based guidelines and practical resources, but is by no means exhaustive. So I'm not going to read all of these out, but I would like to just note that many cancer nutrition evidence-based guidelines and resources available to us have been developed in Australia. So there really are some leaders in this space in our own country. I'd like to highlight the fantastic COSA implementation toolkit. So where that red arrow is on your screen, this provides a really great repository of information, worked case studies and references to support implementing the recommendations from the COSA cancer-related malnutrition and sarcopenia position statement. Here are some further key resources. So these ones are specific to the AYA population, if this is a group that you might be working with. And again, not an exhaustive list, but here are some key resources for use with your patients and their carers. But you can also use these to support your own or perhaps multidisciplinary learning in regards to cancer nutrition. And if you're someone who'd like to be better connected to the world of cancer nutrition, perhaps to support your own PD, or if you're just looking for a great conference to attend, here are a few details. So just a couple of shout outs here. I'm going to shout out to the COSA Nutrition Group, which is a leading group of dietitians working in cancer nutrition care and research, who really are driving new evidence-based guidelines and position statements, providing education and working with a range of multidisciplinary cancer experts across Australia. There's also some great conferences coming up if you're looking to get in before the end of the financial year. Noting that COSA, the Clinical Oncology Society of Australia, is in Adelaide in November. We'll be hosting Professor Carla Prado as the international speaker at that conference. We have a conference called MASK, which is coming up in Melbourne in 2026. So this is the Multinational Association of Supportive Care and Cancer. So a really big international cancer conference, which is being held locally for the first time in a long time. So that's a great one to put into your calendar. And I'm going to give a quick plug to the Peter Mac's Talking About the C Word one-day nutrition PD event, which will be held on Friday, the 5th of September in Melbourne at Peter Mac. So we would love to see you there. So just to sum things up for today. So nutrition in cancer care is vital, and life stage is really critical to consider. So multidisciplinary and collaborative teamwork needs to be standard care and really absolutely should wrap around the patient. The foundations of cancer nutrition care are essential, and we haven't really covered those today. But what I mean by that is don't forget the basics. So that is, you need systems that include nutrition screening and promote proactive blanket referrals for known high-risk cancer groups. You need to conduct comprehensive nutrition assessments. So in oncology, that should include the use of the PGSGA, and also it's critical to prescribe practical, individualized, and tailored nutrition interventions. So I encourage you to be aware of who the patient is in front of you. I want you to think critically about what's important to the patient and also to your care. And if you can, offer a creative and pragmatic approach to your cancer patients, unique to their life stage. And thank you very much.